How many of you think stress had something to do with what happened to your heart? Anybody think that? There's a lot of information pointing in that direction, and I'd like to share some of that research with you. And the second reason I think this is such an important topic is because your doctors, bless their hearts, they take a whole lot of time talking to you all about your blood pressure or your cholesterol or your heart rhythm, those kinds of things. It's not very often that doctors take the time or have the time to speak with you about how this cardiac event has affected you emotionally or psychologically or spiritually, or what's happened to your family as a result of this cardiac event. And I think that in cardiac rehab, we're talking about healing of the whole person. And so when we're talking about a whole person, we can't just talk about the physical side of heart disease. If we're going to talk about whole healing, we must address psychological, emotional, and spiritual healing. And that's what this class is about today. And I mean this to be a very casual conversation, and I also want to be very clear that everything we talk about today is not directed just to the patients. This class is for everybody, because believe me, your family members went through your cardiac event with you, and they need to heal just as much. Hi, fine. They need to heal just as much psychologically and spiritually, okay, and emotionally. So, we have to start a stress talk somewhere. And in all my research, every single definition of stress starts with that word, demand. And I think that if you guys are all alive and breathing, you can admit that you have demands on you. You know, whether it's taking care of children, getting to work on time, or having something happen to your health. We all have demands. And the number one most important point of this whole talk is, it doesn't matter. It absolutely doesn't matter whatever life has dished out to you in terms of your stress response. The only thing that matters is your perception of your life. Okay? As human beings, every single time we walk into a situation, we assess it. That's what humans do. What does this mean to me? And in fact, this process is indeed what gives all of our lives meaning. Because whatever meaning you give to what you find on your plate absolutely 100% determines your response to it. Okay? Now, in general, this is a big generalization, but in general, there's one of two meanings that every person gives to a stress or demand. These are the words I use. I use the words challenge versus threat. Some researchers call this good stress or bad stress. Some researchers call this eustress, distress. It doesn't matter, it's all the same thing. And the point being, if you take an individual and put them in a stress or demand situation and they see challenge for themselves, they're going to respond with stimulation, with vigor. It's actually a pretty cool experience to have. And as a matter of fact, in the health psychology literature these days, there's a lot of discussion about the importance of all people having a certain degree of stimulation in their lives. It's what keeps us viable and active and alive. And one of the things that we have with geriatric populations, one of the challenges, is a lack of stimulation. They quit working, they lose their social context, and with that lack of stimulation comes all kinds of problems, depression and everything else. So we believe that some degree of good stress, some degree of challenge, of stimulation, is something that we should all have and maybe even pursue in our lives. But the interesting point is, you could take a different person and put them in the exact same situation, and they see threat. They don't see challenge. And so their response, therefore, is going to be 180 degrees different. And what we believe is that that's where the problem lies, is this continual perception of threat and the physical response that comes from that. And what we believe is, if this situation happens over and over and over again, it can cause dis-ease in the body. And the problem with that is that there is threat everywhere. There is physical threat. Certainly when all of you found yourselves in the hospital, you perceived accurately physical threat to you. If you're going to go home and find a robber in your house, you're going to perceive accurately physical threat. But there's this whole other area called psychological threat. Example, there is a certain cardiologist that I have to work with who will remain unnamed, okay? And I'll give him credit. He's probably a terrific husband and father. I don't see him that way. And I tell you, every time I have to interact with him, which is a lot, my hands tremble, I get short of breath, my heart pounds. He's not a physical threat to me. He's not going to hit me. What's on the line? I'm afraid he's going to see me as incompetent. I don't even know what. But yet my body's responding to him like I'm facing a robber in my house. So in terms of our problem, it doesn't matter if the threat is physical or psychological. And you know what? It doesn't even matter if the threat is accurate, reality-based, or the threat is totally wacko, magnified, off this world, out of crazy. The response is the same. And what we believe is if that happens over and over again, it can cause dis-ease in the body. Now, for many, many, many years, we have been trying to figure out if there's something psychologically that sets people up to get heart disease. We're looking for a coronary-prone personality. And in about the early 1970s, there were a couple cardiologists in the Bay Area who had this idea of a coronary-prone personality. And you know where they got the idea? They started looking at their patients and seeing there were lots of similarities in personality with cardiac patients. And so they called this, do you know what they called it, 1970? Type A. Type A behavior, type A personality. They defined a type A coronary-prone personality as anybody who had three characteristics. One, these people overall were very competitive. Driven, competitive. Okay? Two, these people were what they called time urgent. They were very impatient. They don't wait in line really well. Things have to get done yesterday. That kind of thing. And the third characteristic was what they called free-floating hostility and anger. And they put together these characteristics into a questionnaire, and they did some research. And what they did was they gave this questionnaire to tens of thousands of healthy men. Men only, by the way, in 1970. They didn't ask women. It's not a problem for me. Okay. Anyway, so and indeed, they found a whole cadre of healthy men who were clearly type A personality, and a whole cadre of healthy men who were clearly not type A. And they followed their health statistics over time. After only 8 years, they discovered that type A guys were 2.5 times more likely to have suffered a heart attack. So they said, hallelujah, we found the key, type A personality. They published their results in 72 or 73, and at that time, everybody jumped on the type A bandwagon, if you remember. The subsequent research that was done was a little confusing because some people found a very strong association between type A and heart disease, and other people found nothing. So what they subsequently did was to investigate the individual components independently. And after 20 some odd years of that, we can say with a very high degree of confidence that the first characteristic of type A, being competitive and being driven, has nothing to do with heart disease. We can also say with a pretty high degree of confidence that the second characteristic, being impatient, time urgent, has nothing to do with heart disease. And you know, I could probably build a case to say that any individual who has those two characteristics is probably benefited in our society, right? Those kinds of people, competitive, driven, time urgent people, are productive, successful people. They get things done, right? But the third characteristic of type A, this idea of anger and hostility, kept falling out and falling out and falling out of the research until today, in the year 2009, We're not talking about the type A coronary prone personality any longer. We're speaking of a different coronary prone personality, and that is the hostile personality. Hostility, or the hostile personality, is now associated with the development of heart disease, cancer, all forms of mortality, the incidence of violence and suicide. So the hostile personality is a real hot topic right now. I want to share some of this research with you with one caveat. One time I was doing this talk and somebody in the room thought I was saying that if they had heart disease, that meant they were a hostile person. Okay? And that's not what I'm saying at all. That's not what I'm saying at all. You know, for some people, they have a history of smoking or high blood pressure or high cholesterol. For some people, this may be coming into play. Okay? So let me describe for you how we're defining a hostile personality, and you can see if that fits for you or for somebody that you know and love. Okay? So, a hostile personality is defined very simply, and that's by how hostile people think, feel, and act. So it's very simple. The thinking, the cognitive component. Hostile personalities have a set of negative attitudes, negative beliefs, negative appraisals of other people. So a hostile personality thinks everybody else is stupid, everybody else is a jerk, everybody else is a thief, everybody else is, okay, that kind of thinking. Hostile personalities, they anticipate provocation, they anticipate mistreatment from other people. So they're always kind of on guard. And a huge thing is mistrust. Hostile personalities have huge trust issues. The affective, the feeling part of hostility. Hostile personalities have a tendency to feel angry, irritable, annoyed, resentful, pretty much on a daily basis. They're what we call anger prone. This does not mean if you've ever gotten angry in your life, you're a hostile person. Anger is a human emotion. We all get angry. But with hostile personalities, they're very easily triggered into anger. Almost any arousal, boom, goes into anger. And once they get angry, boy, they hold on to it for a while. It takes them a while to calm down after they get angry. The behavioral part is pretty predictable. Hostile personalities have a tendency to react to being aggravated with expressions of aggression, either verbal or physical. They tend to be rude and uncooperative. When I came upon this literature about 15 years ago, I became pretty alarmed because this definition is my husband. Now, not all the time. Hostile personalities can be warm and funny and brilliant and productive, and my husband is all those things. But for example, put my Michael behind the wheel of a car. Have somebody do something wrong. Okay? That's hostility. Now, what could be the link between hostility and heart disease? What researchers call this is a cajillion-dollar word, I love this word, psychophysiological cardiovascular reactivity. Isn't that good? And all that means is we have discovered that hostile people are hot reactors physically. So you all know when any human being gets aroused, anxious, angry, gets any of those feelings happening, you have an increase in heart rate, increase in blood pressure, increase in all those stress hormones, right? That happens to every human body. Turns out, when hostile personalities feel those emotions, they have an exaggerated physiology. Their heart rates, blood pressures, catecholamines, all those stress, they really, really increase higher than normal. And what we believe is, if this response then happens repeatedly, daily, maybe frequently in the course of a day, that's what's putting the wear and tear on the cardiovascular system. Make sense? So that's the theory between hostility and heart disease. We believe that the hostile personality is stable, meaning that once a person's hostile, they're not going to change. My husband's going to die a hostile personality. He's not going to change. I know. Okay? So the research now, they're looking at, well, how do we protect hostile personalities from disease then? What do we do? And so the things that they're investigating, there's two things they're investigating. One is anger management, and the other is assertion training, coupling both of those with relaxation techniques. And they're thinking maybe they may be able to blunt the physiology. Is that going to work? Who knows? Who knows? But that's what they're investigating. The research has evolved over time, and now they're doing some very interesting things, and they're looking at hostile personality and their anger style. And the two anger styles they're looking at is hostile anger out. That's my husband. He's an anger out. When he's mad, you know about it 3 blocks away, okay? That's anger out. But there's also a whole heck of a lot of hostile people who are anger in. They're feeling the exact same stuff, but you'd never know it. Anger in. And what they're looking at, which is going to be interesting, they're looking at gender differences. What do you think? Women, anger out or anger in? You think in? Uh-oh. Yeah. You know what I think they're going to find? I think they're going to find a ton of women in my mother's generation who are anger in. I do not believe that's going to be true for my daughter's generation. Yeah, so we'll have to see how that pans out. The other thing they're looking at, which is going to be fascinating, is the incidence of cancer and heart disease with anger out, anger in. Won't that be interesting? I have absolutely no idea what they're going to find, but my intuition, I'll bet you less than a penny, but my intuition tells me we're going to find anger out, heart disease, anger in, cancer. It just makes intuitive sense to me, but I don't know. So they are publishing the results of these studies continually. I'll bet I find an article in the Register Guard once a month in this area. And if it's in the Register Guard, it must be true, right? It's a joke. So keep your eyes open because, as I say, they're publishing this stuff all the time. We are interested in how it is that a person becomes hostile. Are they just born that way? Is this a genetic predisposition? Or do you think it's learned? What do you think? Learned or genetic? Mm-hmm. Yeah. They've done these studies of identical twins separated at birth, and they cannot find a strong genetic pull for it. And so they believe it's learned. And the latest developmental research has posted 4 risk factors developmentally in children for development of a hostile personality. And that is environments of no talking. I think this is an old way of parenting, but it used to be children are to be seen and not heard. So if they grow up in that kind of an environment, no talking, no feeling. So if they do express something, they're told they're wrong. You shouldn't feel that way. Boys don't cry. So a lot of suppression of feeling. So no talking, no feeling, no touching, so a lack of affectionate touch in their lives or inappropriate touching. And the 4th condition is no trust. So they're in environments where they feel there's no one they can turn to, no one they can lean upon if they need. And they're saying that these are risk factors then for the development of a hostile personality, which is really disturbing when you think about some of the environments our children are growing up in these days. What the heck are we doing to them? And there was one more piece of research. Are you guys finding this interesting? There was one more piece of research I found really interesting, and that was because we believe that the hostile personality is stable over time. There was one group of researchers that went to high schools, and they gave the hostility questionnaire to high school kids, and indeed they found a whole cadre of hostile adolescents. They followed those kids for 10 years into adulthood, and what they discovered were the hostile adolescents, as adults, tended to smoke cigarettes more than the normal population, eat more calories, have higher body weights, have higher blood pressures, and drink more alcohol. So, hostility and heart disease may be linked very simply because hostile people tend to do risk factor things. We haven't sorted that out yet. So stay tuned. That's something we're going to be investigating a lot. And And just so you know, I'm fascinated by this area, and I'm always going to conferences in this area, and currently we're also looking at the effect of chronic anxiety on the heart and clinical depression. And that also makes intuitive sense to me that any negative emotion may have impact on the heart. So, you know, as 30 years ago we were speaking of the type A coronary prone personality, we're currently talking of the hostile coronary prone. Maybe in another 20 years we'll be talking about the maladapted personality. You know, maybe any negative emotion has an effect on our hearts. I don't know. So stay tuned. Yes?
So if negative stuff has an effect on your heart, positive effects would have really a lot of benefit for you.
I have to repeat your question because I got this monitor on. So he was speculating that if negative emotions can have a negative impact, probably positive emotions would have a positive impact, and of course they're investigating that as well. Yeah. And yeah, that's a really exciting area for me personally. So, how many of you think you might be a hostile personality? One person in this whole room. Well, just in case you're interested, I do have the latest and greatest hostility questionnaire hot off the press. This is done by the main man in the field. His name is Dr. Redford Williams. He's out of Duke. And this is his most current hostility profile. This questionnaire, I'm going to just leave it up here. I'll give it to you at the end. You can take one or not. It doesn't matter. And it tells you how to score it in the back. And certainly if you find that you're a hostile personality, don't go and slash your wrist or anything. It's just kind of for fun. Okay? You can take this. The questionnaire is very interesting because when you go through the questionnaire, it's totally obvious what the hostile answer is. And so Dr. Williams says, look, you have to take this straight from your gut. No social desirability. Answer honestly. He said, or you may want to give it to somebody who knows you very well and let them take the questionnaire about you. He said you might get some interesting feedback. I, of course, have shared this information with my husband. And now we drive along in the car, somebody will do something nuts, and I'll sit there, and he'll look at me and he'll say, you see, I'm fine. But the blood vessel in his neck are sticking up. You know, so he's gone from my anger out to an anger in. Is that healthier? No. All right. So life gives us all something to deal with. And for a heck of a lot of us, you tend to see threat, and then you have a response. The response, I'm going to write this on the board, and you tell me what it means. What's the FF response? The FF, the fight or flight response, that's right. Now, we've known about this since the 1920s. And the fight or flight response has been defined as a very instinctual response to a life-threatening situation. It comes from the primitive brain. There's no cognition. It's totally instinct. And what happens when that kicks in is your body goes through an enormous physical preparation for sudden exertion. Okay? Fight or flee. That's why they call it that. Now, you all have a pretty good basis of understanding of cardiac function from these other classes. I'm going to read off a list to you of what happens during fight or flight. Please consider for me what could be the effect of fight or flight on your heart. So, the minute you recognize a life-threatening situation, bang, the floodgates to all those stress hormones are opened up. Some people say, ooh, I had an adrenaline rush. Indeed you did. Adrenaline, noradrenaline, epinephrine, norepinephrine, catecholamines, cortisol, all of those things flooded into your system. With that, bang, heart rate goes up. Bang, blood pressure goes up. Remember, from lecture 1, we talked about arteries and veins. Arteries are kind of cool because they have muscle cells around them, right? Remember? And so an artery then has the ability to dilate, to relax and open up, or it has the ability to constrict and close down. What do you think happens in fight or flight? Do you open or constrict? You constrict. Okay, bang, especially the ones in your extremities. So if you were to become injured, you would have slower blood loss. So somebody who's in fight or flight will have real cold hands and cold feet from the clamping down of the arteries. Increase in breathing rate, and your breathing passages widen up. Why? What are you trying to get in? Oxygen, oxygen to power everything. You start to perspire. Now, why are you perspiring? Why are you sweating? You want to prevent something. You want to lose heat. Heat. Yeah, you want to lose heat so you keep your body still functioning. How many people in here have diabetes? What happens to blood sugar under stress? Okay, so you dump sugar into your blood. You also dump fat. Now, why would you dump sugar and fat into your bloodstream? What do you want? Energy, fuel, that's right. You have an increase in clotting factors. Remember those clotting factors and those sticky platelets? Flooded into the bloodstream. You have an increase in sensory activation. Your pupils dilate. You can see better, you can smell better, you can hear better. And all of the skeletal muscles in your body tense for action. Have any of you ever almost gotten into a car accident and you slam on the brakes and then you don't get in the accident? What happens to your legs after that? That's that instant muscle tension that has to be released. Now, what could be the consequence to your heart? Any ideas?
Increased workload, increased pressure.
Increased workload, and for some susceptible people, that could be too much. Now, we have some very interesting abilities because of technology. And it turns out that you can go with computer databases and punch in any day, anywhere in the world and get medical data. And so this one group of researchers was very curious about the medical data in a 24-hour period in 1994 in Northridge, California. What happened in 1994 in Northridge, California? Yeah, it was a big earthquake. It dropped shopping malls, it dropped freeways. 193 people died in the Northridge earthquake. 27 of those were from the earthquake. The rest were cardiac. Yeah. Now, Northridge, California is in a pretty populated area of Greater Los Angeles. There are 71 medical centers in Greater Los Angeles. If you go to an average day in Greater Los Angeles and punch data, they will report 3 sudden cardiac deaths. That's where people just crumple over and die. In the 24 hours after the quake, they went from an average of 3 to 29. Those 71 medical centers reported a 35% surge in admissions for heart attack in the 24 hours after the quake from an average day. And they also went to those implantable defibrillators people have. They have records inside of them. And they pulled the records and they found a 24% increase in discharges for death rhythms in the 24 hours after the quake. So, can fight or flight have a cardiac influence? Yeah. Cardiac consequence? Of course. And I don't want to denigrate this response at all. This is a beautiful response that we can access if you're going to go home and find a robber in your house. But unfortunately, we can access it when Sharon sees a cardiologist in the hall. Okay? And in those kinds of situations, I can't fulfill fight or flight in the way nature intended. I can't punch the doctor or run. I like my job. And so we're just left to sit there and stew in these juices we're producing, which is not healthy. Because what we have discovered is that the body has a way to calm down. And so any response, your body wants to come back to equilibrium. Now, this is something we're just starting to understand. And you know something we found out just recently? Men and women are different. Is that not a shocker? Yeah. Men and women are different. And where they differ is in their bodies coming back down to equilibrium. So the normal natural thing is you respond, you react, you relax. You respond, react, and then relax. And this relaxation part is driven by something called oxytocin. Oxytocin is sex hormonally mediated. Female sex hormones amplify oxytocin relaxation. Male sex hormones inhibit oxytocin relaxation. Now, probably the theory is that the reason that is because in primitive times, the women had to get it together to pick up the babies, right, save the tribe, and the men had to stay vigilant. They had to stay up to protect the tribe. And so that's probably why that evolved that way. And if you look at the anger research, anger is much more deadly for men than women. Probably because they don't have the ability to calm down like women do. If you look at the hostility research, hostility is much more deadly for postmenopausal women because they've lost that ability to calm down. Okay? Very, very, very interesting. Oxytocin, they call it the bonding biochemical. And you want to hear a secret? I'll tell you a secret. Don't tell anybody, okay? And the secret is you can cause a surge of oxytocin in a woman. And you know how you do it? You touch her. You cuddle her. You hold her hand. And she gets a little spurge of oxytocin. And she loves that. That's why women like to cuddle so much. Doesn't happen for men. There's only one thing that will spike a man's oxytocin. You know what it is?
A good meal.
No. She said a good meal. No. No. Yes. Orgasm. Orgasm will spike a man's oxytocin. And that's that wonderful flood of relaxation you guys feel after orgasm. That's oxytocin. That's a joke in my house. My husband will say, I need a spike in my oxytocin. And you know what I say, don't you?
That's a good line.
Yeah. Okay. Oh, this fight or flight is an acute stress response. There's also chronic stress responses that we're looking at. One of the chronic stress responses we're looking at a lot is the influence of cortisol. You guys have heard of cortisol, yeah? It's a big thing in the news these days, cortisol. Cortisol is a reaction to chronic stress. Now, what's very interesting about cortisol is that in a normal, healthy, wonderful body, it starts at baseline when you wake up in the morning. And then as you go through your day, your cortisol level rises. And that's a wonderful thing. I would not want to drive the freeway if my cortisol level wasn't up. It helps my reaction time. Okay, that's a good thing. And then we found out as you sleep, your cortisol level returns back down to baseline. There are some researchers that believe that one of the primary drivers for sleep is to return cortisol to baseline. Here's the interesting thing. For most of human history, we have slept for 10 hours a night. Perhaps 10 hours is what's required to bring cortisol back down to baseline. A generation ago, we had reduced our average sleep time to 8 hours. We are currently averaging 6.7 hours. So as a result, those who are sleep deprived, we're walking around with chronically elevated cortisol levels. They never get the opportunity to return all the way to baseline. Chronically elevated cortisol levels are not normal, not natural, and have huge consequences. 1, some people find that when they feel stressed, they feel hungry. Anybody find that? And when you're stressed and you feel hungry, what do you want? What kind of food? Carbohydrate. And that is the stress response. Your body, the cortisol level is signaling your body that you're stressed and you need energy. So you may have had a full breakfast, you have no need for any more calories, but yet you're taking in more calories because you're getting the signal to do that. There is one area of our body that has 4 times more cortisol receptors than any other area, and that is the most unhealthy place to store extra calories. Where would that be? So see how dysfunctional this is? So your body's telling you to eat more calories and you're storing them in the most unhealthy place. Completely unnatural, completely dysfunctional. We've also found that people who have elevated levels of cortisol have accelerated atherosclerosis, speeding up the plaquing process in their arteries. So if some of you feel that you were living under a lot of stress and that's what brought you to cardiac rehab, you're right. In that what it may have done is bring you to us sooner and younger than you would have otherwise because of the accelerated plaquing. Elevated cortisol levels also depress immune function. Have you ever known somebody who had a lot of stress in their lives and it seems like they were always sick? They always had a cold or the flu or whatever bug was going around. Now we know why. Because of the elevated cortisol level, it compromised their immune function. They couldn't fight off those bugs. That's why they're always sick. People who are clinically depressed have elevated cortisol levels. People who are suicidal have elevated cortisol levels. And don't you find this interesting? No, that's not the right answer. Because does this help you? And what I guess what my soapbox is human beings know themselves very well. They know themselves very well. We know when we're under stress, and you all know what your stress response is. I'm going to read off a very abbreviated list of physical complaints that we know are stress-related. And please raise your hand if you've ever had any of these complaints. Let's see how common they are in a small group of people. So your body under stress. Anyone ever get a tension headache or migraines? Muscle cramps or muscle spasms? Back pain, neck pain, shoulder pain, high blood pressure, skin problems, constipation, diarrhea, insomnia, fatigue, okay? Sexual dysfunction. Don't have to hold up your hand. Okay. And there's one more. There's one more. And that is asthma. Some people don't know that that can be a stress response. And I know that the reason that I chose cardiac rehab for my life work is because my dad had his first heart attack when he was 31 years old. He had a second massive heart attack 8 years later, and that killed him. At the time, my mom was a 39-year-old, healthy, athletic girl who suddenly found herself with 2 little kids. My mom had never been sick a day in my little life. The night of my dad's funeral, she came in and woke me up because she couldn't breathe. She got asthma the night of his funeral. She was on inhalers for about a year and then got off of them. It was a stress response. Now here again is another one of my soapboxes. You know you're under stress. You know what's going on in your body. You go to the doctor and you say, I'm having blah, blah symptom. And the doctor then gives you medication for your symptom. Your symptom isn't the problem. Okay? My mother needed somebody to put their arms around her and convince her she could survive. Instead, she got inhalers. Okay? And what the big picture is, again, is that you're stuck. You can't change this. My father had died. She couldn't change that. But where do we have power in this stress response? Well, we have power right here. What do you say about you? There's that very interesting thing called conscious language, about listening to yourself talk. What do you say to yourself when you get into these kind of situations? Oh, good. This is a good challenge. Or this. It dictates your response. Something I've tried in the last couple of years. I've tried to live right here. I say it out loud to myself. Oh, good challenge. Okay? I just don't even go there. And is your body helping you or hurting you? Now today at the end of class, we're going to spend about 5 minutes. I'm going to show you a technique that's the opposite of fight or flight. And what we're going to do is we're going to take a pulse, practice that technique, and then take a pulse again. If you can do it, it's a skill. And if you can do it, you'll slow your pulse down. It's a wonderful skill to practice. Another area we have control of is how we cope with all our nonsense. And I really believe that how we cope determines our final life outcome. Whether or not there's going to be a positive or a negative outcome, I think, is predicated on how we cope. This is where stress management comes in. Okay? Now, we have studied the ways that people cope, emotionally recover from demands, health demands in particular. And what we have discovered is that coping and recovering, emotionally recovering, is a process. It's a process that has identifiable stages in it. And whenever I'm talking to you guys in the gym, I'm always very interested to listen to the words that you're using, because I'm trying to figure out where you are in your process. And I have no problem at all with you experiencing that process. I think what happens emotionally that causes trouble is if people get stuck in a stage. Okay? So let me describe for you the stages of this process. And you can figure out maybe where you are in your emotional recovery. Okay? And to do that, I need all of you to take yourselves back in time to the exact moment your cardiac event began. The exact moment. And I don't know where you were. You could have been riding in an ambulance. You could have been lying on a gurney in the ER. You could have been sitting with your doctor. Take yourself back in time to that moment. And when you're in that moment, the very first stage is denial. Oh my God, this can't be happening. You all said it. There's a lot of prayer in denial. Please, 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 can't be that bad, can't be. Everybody does it. And I think initially that kind of denial is incredibly beneficial because nobody can or should have to integrate the enormity of what heart disease means in your life when you're laying on that gurney in the ER. It's too much. So a little bit of can't be, it's going to be okay, it's going to be okay, it's, all that kind of stuff is, I think, really beneficial. Unfortunately, many patients get stuck right there in denial. Well, how does that look in cardiac rehab? Well, they're coming in every week for their therapy, and yet they're still smoking. You want to go? Hello? And then, when you talk to them, they say things like, well, my doc said I had a little tiny heart attack. My doctor said I didn't have any heart damage. That's a good blood pressure, right? You can feel them backing away from it. And of course, somebody who's in denial of this process doesn't have to make the changes that they need to thrive. So denial is a very comfy place to live. But of course, we have to break through that denial, and it's not very fun for the patient, it's not fun for us, but incredibly important to do. Once people get through the denial and they get it, that this is now a part of them for the rest of their lives, when that epiphany happens, there is a sense of loss. Everyone feels loss of all kinds of things, okay? And when humans feel loss, what do? We grieve, we mourn. And so oftentimes people are blue, they are tearful. I've had people come in and say, I don't know what's wrong with me. I have turned into Mr. Waterworks. I can't even watch the damn TV without crying. We're in the next stage, okay? Absolutely appropriate and normal. It's been estimated that 99% of patients have a transient depression after their cardiac diagnosis, to which they rapidly recover. Now, the issue that I have in this area is that there's a proportion of people to where this normal transient depression gets deeper and deeper and deeper, and they find it difficult to even get out of bed and get dressed in the morning. And that's not the normal response anymore. That's called clinical depression. And we're concerned about clinical depression because what we discovered is clinically depressed cardiac patients who do not address the depression die. And we don't know why. We're investigating there may be some rhythm changes with depression, there may be some clotting changes with depression, or it may just be that depressed people just don't take care of themselves. They tend not to take their medicine, they tend not to go to their appointments, they tend to keep smoking, that kind of thing. But the last national conference I went to on depression, the psychiatrist stood up in front of a national audience and said, if any of you recognize clinical depression in your patients and you do not get that patient medicated, consider that malpractice. Now that's a very strong statement, but that's just how seriously we consider clinical depression in cardiac patients. So the going home teaching point is everybody gets blue. That's normal. It's normal. But if you're finding it difficult to even live your life, let's talk, okay? Another stage is anger. People feel cheated, resentful. Why me? I don't deserve this, that kind of thing. And I, some people will come in sometimes and say, you got to help me here, I'm screaming at my kids for no reason at all. I'm losing my temper at work. People are shunning me, And I say, and I'll tell you that I love angry patients. I love them. Because you have to look what's underneath the anger. And what's underneath anger, I want to live. Damn it. Excuse my French. Okay? There's some life juice. There's some life passion there. It's real different than the giving up that happens with depression. So I know anger is not a fun thing to feel. I know it's not a fun thing to be around. But please celebrate the juice that's behind it. Good stuff. Here is the problem. There is a societal, cultural ethic that's placed on every single patient. And this ethic, you all subscribe to it. Okay? And that ethic is, if you are a patient, you shall be a good patient. And you all are. I'm over in the hospital. I walk into your rooms. I know how miserable a time it is for you, and yet you smile at me every time. Trying to be a good patient. And you may be having, one of the bluest day you've had in a while. And yet your dearest friend will come up to you with all the love they have in their heart. And they'll say, hey, how are you doing today? And what do you say? Fine. Fine.
I'm here.
Yeah. And all these feelings we're talking about are absolutely normal, appropriate responses. They are. And one of the things we've known for a long time is the way that you move on is to let it out, right? How many of you been through the military? Anybody been through the military? In the military, they have a very interesting thing called debriefing. Debriefing, ever heard of that? And what happens is you bring a traumatized soldier in and you have them talk and talk and talk and talk and talk and talk and talk. And you know what? They get over it. Debriefing. That's how people get over it. They talk about it. Okay? And for the patients, please recognize that your family members have to subscribe to their cultural ethic that's placed on them, and that is, if you are the family member of a patient, you shall be brave and strong. And they are. Let me tell you what it's like to look in the face of a family member as their loved one is being wheeled off to surgery. What do you hear? Okay, sweetheart, I love you. I love you. I'm right here. I'm right here. I'll see you in a couple of hours. I'm right here. I love you. I'm right. Brave and strong. I won't even give them eye contact anymore. They're working too hard. And you need to know this, that your family members love you. And because they love you, they are having emotional reactions to what's happened to you and to your lives together. Your family members feel cheated and angry and resentful and scared and sad and everything you feel. Everything you feel. But you know what? They will never tell you. Why? Because if they tell you that, that might upset you in some way. And if you get upset, that might hurt you, and they're not going to do a darn thing to endanger you. So what do they do with all their feelings? They hold them inside. Isn't this crazy? How do we know people get to emotional recovery? Talk about it. So, for family members, if your patient's having a bad day, help them get it out. Give them a tissue to cry it out. Help them get it out. And please, for family members, go home and tell your family that you're not that darn fragile. And how are they doing? It's okay. It's just normal stuff. And I certainly recognize that there are some families where talking is not okay. And I certainly recognize that there are some people that have no families, they're all by themselves. So I want you to know that cardiac rehab is safe. When you come in every week and we ask you how you are, we're not asking how are you to hear you say fine. We're asking how are you because we want to know. and it's okay to talk about it. And I can also make you a promise. For all you people that are exercising together in the gym, if any of you are in the gym and you see somebody having a bad day, is that going to be a problem for anybody in here? No, because you all get it. You all understand. Cardiac rehab is safe. And I felt so strongly about this that I went to the hospital administration many years ago, and I asked them if I could provide a support group for patients and their families. And the hospital said, sure. I was surprised. It was just that easy. So I have been providing a support group at no charge for 14 years. It's done on the second Thursday of every month, and I will give you a flyer about that. The group is from 6:30 to 8 at night, so if you're even back at work, you can still come. The group, you don't have to come to the group, but if you ever feel a need, just know that it's here. It's held in this room here. And the group is very interesting. Sometimes people come to group and their cardiac event is very fresh and they just want to talk to other people who have been there. Other times people come to group and their event was 15 or 20 years ago. You know what they want to talk about? Motivation to keep on track or keep on with their exercise. Or I had a guy come a couple of months ago and his wife was the patient. He came all by himself. And he said, I'm here because my wife is really having a hard time and I keep trying to help her and she keeps saying, you don't understand, you just don't understand. And he said, I'm here because I'm trying to understand. So the group's interesting. Know that it's there. Know that it's free. You don't have to make an appointment or anything. Just come if you ever feel a need for it. And that's this month or next year or 10 years from now, I'll still be doing it. Okay? So, life gave you all something to deal with. Okay? I know none of you wanted this. I know none of you asked for this. But there it is. And I think the first process in all of this is what kind of meaning are you going to give this? I think it would be reasonable to see it as a threat. You could see it as the worst thing in the world that's ever happened to you, involving enormous loss, terrible, terrible, terrible. I mean, you could choose to see it that way. But what I would encourage is if you could frame it like this. And I don't want to be maudlin, but you all know that a lot of people that came into the hospital like you all did, didn't get to leave. That's just true. There's some reason all of you got to get up and walk out of that hospital. And so I say grab this by the you-know-what and run with it. And celebrate the kinds of changes you're now capable of making. And I promise you, if you do some of the things we're talking about in cardiac rehab, you may feel better than you have felt in decades. Okay? Now I have a handout that I'm going to go over real quickly. And then I want to do that practice for 5 minutes. This is effective stress management. We're going to go over this front page. The second page is a reading list. And I've got them in categories of some of my favorite books in these areas. And the third page, stress managers, just something you can stick on your refrigerator to remind you what you should do every day. So the first page, effective stress management. There are 5 techniques on the front page. And these techniques, I believe, if we practice them every day, it will make an enormous difference in life. Okay? So number 1, exercise. Now last time we talked about the physiological benefit you get from exercise. And indeed there's huge physiological benefit. Please also remember the psychological benefit you get from exercise. We know about reduction in anxiety, depression. It's a wonderful way to burn up all those stress chemicals you've built up from seeing the cardiologist in the hall. I do it every day. So think about exercise in terms of your ability to manage stress. It's one of the primary reasons I exercise. And when I have to miss exercise sometimes, my husband will say to me, honey, you need to go to the gym. And he's right. You know, we call it gym Prozac. Okay? Relaxation techniques. I'm going to come back to this because that's what we're going to practice. Social connections, number 3. I don't want to beat this to death, but please recognize that human beings are animals that need connection. And I'm not talking about the kind of connection we get from talking about the duck game or the weather, okay? But finding people that we can talk to about the things that really, really matter in life. And if nothing else, you know that you have the support group. Pursuit of happiness is number 4. And I put this in, frankly, because I'm sick to death of talking about avoiding stress, avoiding stress, avoiding stress. Why not pursue happiness, what you were talking about earlier, experiencing positive things, okay? Now, the interesting part about cardiac patients is that you all are indeed type A personalities. You are. You are. And type A personalities take care of everyone and everything before they take care of themselves. You just do. I know that about you. I know that about you. And so I'm sitting here right now in front of God and everybody, giving you permission to take care of yourself. And I don't even know if you remember how to do that. You may want to sit down tonight and make up a list. I like to, what? What is it that brings you pleasure, that makes your heart happy, that makes you want to giggle inside, that makes you feel relaxed, that makes you feel, you know, what are those things? You may have to start scheduling them in your lives. And I promise, if you do that, pursuing that in a positive way, it's going to have a hugely positive impact on your life. The last thing is spiritual connectedness. Whether it's taking a walk in the woods or whether it's going to church, we all need to be in a place where we can think about meaning and give gratitude. One of the things my husband and I have been practicing the last couple of years is we give a gratitude every night before our evening meal. Sometimes it's hard to find something, you know, that happened that day that was good, you know, but it's a wonderful way to end the day, to think about what is good in our lives, you know. Gratitude's very important. Please find your pulse. If you can't find it, it's okay, but if you can, that would be great. I'll tell you when to start counting and when to stop. Get ready. Count. Stop. Remember that number. Okay. The simplest and the easiest relaxation technique to do is just breathing. And what we're going to do is we're going to practice this technique for about 3 minutes, and then we'll take another pulse. If you can do the technique, your pulse will slow down, but it is a skill that requires practice. And it does require a certain position. So please scoot your hips all the way back into the chair. Lean back in the chair, uncross your legs so your feet are sitting flat on the floor, relaxing your legs at the hip. So your legs feel supported, your hips feel supported, your low back feels supported. Take your hands, put them palm up, very close into your lap, so you can drop the weight of your arms into your lap. You have a gentle roundness in your shoulders, so you're not sitting up straight and tall. You have a gentle roundness in your shoulders. Neck's in alignment with your spine. Chin tilted down a tiny bit. And then lower your eyes or close your eyes for the next 3 minutes. And by doing that, what you're going to do is eliminate visual distraction and give yourself a little personal space. In the next 3 minutes, you will be distracted. You will be distracted by noise. You may be distracted by your own thoughts. Don't worry about distraction. All you do is focus on the sensation of your breathing. So please begin by slowing your breathing down and allow yourself to take as much time as you need to completely inhale. And when you get to the top of your breath, pause, and then take as much time as you need to completely exhale. So it's a very deep, long, slow breath cycle. For most of the day, we tend to breathe in a shallow, rapid fashion. This is very different. The breathing of relaxation is called abdominal breathing. That means you begin and end each breath with your belly. As you inhale, your belly expands first, then your ribs, up to your chest. As you exhale, chest falls, ribs, and belly get soft at the end. So it's very slow and very deep. Inhale abdominal breath. And as you slowly exhale, say the words to yourself: release, relax, let go. Inhale abdominal breath. And release, relax, let go. Allow your legs to sit heavy in the chair, feet heavy on the floor, arms heavy in your lap. Slow your breathing down. Inhale abdominal breath. And as you completely exhale, let go of toes, feet, ankles, shins, calves. Inhale abdominal breath. And as you gently exhale, let go of top of thigh, relax back of thigh. Let go of buttock muscles, all the muscles of your pelvis. Allow your belly to be very soft and expand as you inhale. And as you slowly exhale, let go of fingers, hands, wrists, forearms, upper arms. Allow your shoulders to drift down. Allow shoulder blades to drift apart. Allow the muscles of the upper spine to relax. Relax middle back. Feel warmth into the low back. Slow your breathing down. Inhale, abdominal breath. And as you completely exhale, in slow motion, allow your head to drift side to side, slowly releasing tension from neck. And when you find the perfect position for your head and neck, allow it to rest. Inhale abdominal breath. And as you slowly exhale, allow jaw to slacken, teeth separate. Allow your tongue to lie easy in your mouth. Let go of cheeks, smooth eyelids, smooth eyebrows, smooth forehead. Relax scalp. Slow your breathing down. Inhale abdominal breath. Release, relax, let go. Inhale with gratitude. Release, relax, let go. Inhale deeply with gratitude. Release, relax, let go. And with eyes remaining closed, please feel for pulse. Inhale abdominal breath, and as you exhale, get ready to count. Ready, count. Stop. Inhale once again, and as you exhale, please open your eyes. Anyone slow their pulse by even one beat? Good. It's a skill. It takes practice. But once you practice this over and over and over again, You'll be able to feel like you're feeling right now in just a couple of breaths. I do it every time I see the doctor in the hall. I do appreciate your time today.